Welcome to One on One, the Daily Items digital program featuring Susquehanna Valley newsmakers interviewed by Daily Item reporters. Today's guest is Evangelical Community Hospital President and CEO Kendra Aucker and Dr. Doyle Ashburn, the Medical Director of Critical Care Medicine.
Hello, my name is Scicchitano. Thanks for joining us today. I'm a reporter with the Daily Item. Today, we're with Kendra Aucker, the President and CEO of Evangelical Hospital, and Dr. Doyle Ashburn, Medical Director of Critical Care Medicine at Evangelical. Thank you both for being with us today.
Thank you.
And Kendra, we wanted to talk about transparency and your pandemic plan. So can you talk about the steps that the hospital took to make it safe for patients and staff? And I throw that question to Dr. Ashburn as well.
Sure. Well, I'll start and then I'll kind of turf it off to him. We have a standing pandemic plan at the hospital, and we adapt that plan whenever something arises. So we have a basic framework that we operate under all the time, and then should something come up, like what happened with COVID-19, we can add to it, and particularly around the areas of infection control, which is a huge part of this respiratory illness. And also part of the pandemic plan is how you plan for surges or an increase in patients. So we always consider those things. And our pandemic plan, I've been reading some articles about transparency, and the Hospital Association of Pennsylvania has asked the state to give hospitals tax breaks during this period of time. Mm-hmm. And just as a relief because of the financial strain on healthcare organizations. And some of the comments back are about the fact that hospitals aren't required to, they're not offering up their plans to show the public, they're not telling how they've increased capacity. And so I agree that hospitals should be sharing their plans and letting the public know exactly how they're addressing those concerns. So what we did was say, in the most simplistic way possible, you're going to have COVID patients and non-COVID patients, and how do you keep them separate? And so, we've begun to institute, we have screenings at every entrance. We've locked down patients to coming in through the emergency room or through one other entrance. Employees come through a designated entrance. They get asked screening questions, they get their temperature tested, and we're trying to limit visitors so that we're really trying to keep COVID out of the building as much as we can. When you come to the emergency room, you get stopped, and if you are there for something non-COVID related and you don't have any COVID symptoms, they'll let you into the emergency room. If you do have COVID-like symptoms, they'll take you to a designated area in what was the ambulance bay where they can keep you out of the hospital. We've also built an extension of that with a tent for the times that we were overflowing a little bit. And then we have the alternative testing site where you drive through and you've seen all of that.
And correct me if I'm wrong, I don't believe, had you had to use the tent area, the extension?
No, we have not. We were close to needing it, which is why we put it up on 1 or 2 days. And then since then, and you've heard me talk about flattening the curve. I mean, I think the social distancing here has worked and it's being pushed down. So we are able to manage that capacity. But then what we had to look at inside the building, which is where I'll begin to turf this off to Dr. Ashburn, is that we've said, okay, we need to keep COVID and non-COVID patients separated. So we have an ICU and we have a step down that function kind of as a team, and the most critically ill patients are in this ICU. But we're going to have ICU needs that are non-COVID related. So we created a second ICU on a different floor to keep it separate, in a different space, to keep it separate from the COVID ICU. We did the same thing with the medical surgical beds and the step-down beds, having a COVID kind of step-down unit and then a regular kind of step-down unit. And we also began to, we had no negative pressure rooms in our ICU or step-down, and we've added negative pressure rooms as well as in the emergency room where we had 1 and we've added 3 and we added 1 in OB. So I'll let Dr. Ashburn talk a little bit about those units and how they work.
Sure.
Yeah, it took a little bit of thinking and work. Our underlying infrastructure, which is one of the reasons we have our prime project going on right now, and building a new wing on the hospital and adding rooms, and part of that project is a new ICU, but we didn't quite get there yet. So, we had to go in and try to modify our existing structure, and working with our plant engineering teams, and we were able to obtain some air handlers, and we were able to set up negative pressure rooms in our existing space, which is very important for infection control and the management of these patients. Our priority here is providing appropriate care, but we also have a very strong priority in trying to control this infection and not spread it, not give it to other patients, not give it to healthcare workers. And in order to do that, trying to keep these folks in a negative pressure room is our goal. So one of the reasons it was very important to do that. So we were able to set up, in our existing ICU, negative pressure rooms with answer rooms where you can go in and put on your protective equipment, and then go in and see the patients and come out and take that off without that being in the common spaces in the hallways and such. And we were able to modify a few rooms out in our existing step-down unit to do that as well. I think that's been very important and very useful in the management of these patients.
Kendra had mentioned, doctor, that there were no negative pressure rooms in the hospital before this pandemic plan went into place. I'm wondering, is that a function because of the age of the facility, and will there remain negative pressure rooms in the months and years to come?
Well, we actually did have some negative pressure rooms in the hospital. We had a few. We had one room in our existing ICU that was set up to become a negative pressure room, because we have to be prepared for managing folks with tuberculosis, which would be one of the most common reasons we would use a negative pressure room prior to this pandemic, and other infectious diseases. But I think that, so we had a few, but we didn't have enough to manage a pandemic crisis like this. So that's why we had to develop some more. And yes, our new plan for our new ICU does include negative pressure rooms, or did include negative pressure rooms in that new build, because we realized that we would need more than what we had existing. So it was one of the reasons for the, in developing and building our new ICU.
Was there any difficulty in making patients feel comfortable once these, segregation measures were taken into place to separate COVID area from the main population of the hospital?
Well, difficulty, you mean patients being uncomfortable?
I think people were anxious, uncomfortable. Like, what steps did staff take to make people, feel reassured that they were safe where they were at, whether they were in the COVID area or outside of it?
Yeah, I think that it's been an interesting phenomenon with the patients coming in, and how much people really do know and understand this. I think there's been a lot of education being done, and and where folks are a little concerned, I think people are a bit scared about being in the hospital and then being separated from their families and not being able to have visitors too. But they seem very understanding of everything that we've done, which is refreshing to a degree. We do spend a lot of time educating the patients and talking to them about it, reassuring them as far as our infection control measures and safety measures that we're taking for them to make sure that they're staying safe. We spend a lot of time talking with patients' families as well, because they're also very concerned that their loved ones are in the hospital and they're potentially in an area where they're not being socially isolated and socially distanced, and could potentially be exposed. So, a lot of education taking place, and teaching on all ends of that. When folks do go into the isolation rooms, it's been interesting and refreshing that, we'll go in, and some folks, we've asked them to wear masks when we're evaluating them, and they really seem very nice and appropriate, and I haven't had any instances, so far where folks have been resistant to even do that. I think they always seem very gracious and appreciative of what we're doing to try to help them through through their illness at this point.
Kendra,
Yes.
was the mental health of the frontline workers, how did you incorporate that into the pandemic plan?
So I don't know that it is called out specifically in the pandemic plan. It's part of our human resources actions here at the hospital. So even prior to COVID, we had been on a campaign of talking to the workforce about your mental health being as important as your physical health. We had 2 employees who took their own lives over the course of over a year period of time, and we used that and that was a national conversation going on, and we had experienced the same thing as a workforce. So we had changed our benefit structures here to pay the same dollar amount of, or a more affordable amount as your copay for your mental health visits, because oftentimes you seek more visits when you go to seek a mental health visit. So your copay, we expanded our EAP and gave people more visits. And we began to host internal conversations with the workforce. I wrote about it, and throughout the entire COVID situation, we have provided resources to our staff, places they can call, tips, you name it, we have focused on that. But that type of thing is generally not built into your pandemic plan. Your pandemic plan is a little bit more around disaster preparedness and then how you're going to treat the medical condition, so it's a lot about infection control and respiratory, slowing respiratory spread and things like that.
What else did you want to address in the way of the pandemic planning? Because I did have some questions about, the phased reopening at the hospital and in the community as well.
I'm sorry, I think it froze, but as far as, did you want to know more I wanted to talk about with transparency?
Yes.
Yeah, no, I think that all I really wanted to convey was that, this is the community's hospital, and we will share whatever information, that people want to know about how we're doing our business to take care of them during a crisis. So that's really the main part that I wanted to impart. I have some details for you that I can forward afterward that shows actual counts of beds and things like that, so you can see how we've expanded our capacity.
The testing site, how much longer do you anticipate that to be in operation? And you guys have gotten to the point now where it's like 1 hour testing in-house, correct?
So a couple of questions there. We have now been given permission this week to open up to elective surgical cases again. All right, so we are in the process of ramping up to open to elective cases and elective procedures over the course of the next 2 weeks. But at the same time, we have to take care of COVID patients, and we have to make sure that we are separating and keeping COVID patients out of the hospital. So we have not identified a time to close the alternative testing site. We're going to keep it open, and we'll make that determination as we see what happens with the number of positive cases. And it could be that it drops off for a period of time and then comes back. There's a lot of conversation around that. So with use of our mobile medical unit and how we're doing that, we can come back, we can bring it up and down as necessary. So for now, for the next month, we have made the decision in May to keep it open. With regard to testing, we've always had the ability to do on-site testing. It's about the kits that you receive, to be able to use your equipment to do that testing. We have received kits, but we don't have an unlimited supply, and we don't know how they'll be replenished. So we've been working with Dr. Ashburn and the hospitalists to utilize those tests appropriately. So we use them on specific patients. We use them on an emergency room patient who's got, for example, has respiratory, is struggling, and they want to admit them to the COVID unit because it could potentially be COVID. We can now do that testing in-house and say yay or nay. And if it is a not positive COVID person, then we can better utilize our PPE and things like that, where if we had to isolate the patient and wait a couple of days, that's the challenge. So we are right now from the reference labs, the majority of our testing still goes out to reference labs, but we're getting those back in usually under 48 hours. So the testing time of the reference labs has dramatically improved, but the on-site testing gives the physicians the ability to better manage the patient and our resources. And I don't know if you have any, you could probably give the criteria for that better than I can, Dr. Ashburn.
Yeah, I mean, you know, so clearly anybody that comes into the hospital with classic symptoms of, you know, viral prodrome, fever, chills, shortness of breath, has infiltrates on their x-ray. Those folks certainly meet criteria to be tested. You know, I think it's important to say how much this has evolved and developed over the past, you know, month even. And when we initially started doing these tests and having to send those out to reference labs, and the reference labs were very inundated with many tests, and it was taking time to get those back. And we felt as though we were utilizing a lot of PPE, you know, in that time frame, and it is just so much better now that we can do these tests in the house and get these results back much quicker, because then we can utilize our resources, as Kendra was saying, our PPE in particularly, you know, to the keep those available for the patients who are actually positive, and then the ones that, you know, are negative, because, you know, we still see your regular bacterial pneumonias and other viral infections, you know, that we're still dealing with as well. So, you know, those folks, then we don't have to utilize the same level of PPE and things for those folks. So it's been nice and very helpful, I think, to get these results back quicker. And they have done, you know, they have ramped up things at the reference lab so that we can get those results back even quicker. But you know, even 48 hours on the inpatient side of things is a long time to, and you can use up a lot of personal protective equipment in 48 hours taking care of a patient. So it's been very useful, very helpful having this testing available in-house.
Kendra, you on several occasions reinforced that Evangelical had a healthy inventory of PPE for, you know, for the patient load that you had and at the time. Can you address that a little bit, where it stands today as far as the hospital's inventory of PPE, and if you're comfortable with it?
I'm very comfortable with where we are. I think some of what Dr. Ashburn said about this on-site testing has helped us conserve. We, in the meantime, because of what I believe has been a beneficial flattening of what we were beginning to see, we've had opportunity for the supply chain to continue its sourcing and secure more PPE. And so that's been very, very helpful to us. And it'll continue to be something we watch, because as you come back up with your ORs, you start using PPE. It's very similar type equipment. And so we've got to make sure that we are doing this slowly and in tandem, and that we are seeing the spread of COVID go down. You know, and they make you watch that. I mean, they'll shut the operations back down again if in the region it begins to spike, because you do burn through your PPE when you open up your operating rooms. So we feel very good about where we are right now, but it'll be a slow, measured introduction of surgical cases and addressing the backlogs and taking time to come back up slowly to make sure that we're monitoring all of this at the same time.
This question could be for either of you. Kendra, you had said that a patient surge may be forthcoming, you know, beyond what Pennsylvania's was predicted to have been, and I believe we've passed that point for the predictions. Do you still see indications that a surge of patients could be in our near future?
Well, I'll give my non-clinical. I am not a clinician, so I'll give my dime-store take on it and let the clinician comment. But, you know, I think that the social distancing has helped, and I think that living rurally has helped. We're just not in as dense of population. And from the forecast that I look at, and I tend to look at what comes from Geisinger and what they're seeing in this region, there's always, everything always has a peak. It's how big will that peak be? You hope that what we've done keeps it down low. And the economy has to open back up. The state's looking at how to slowly bring us back up. And the more you bring it up, people relax and they go out without their masks and they get in crowds and all of that. That's going to be the tipping point on whether there's a resurgence of this. You kind of see from what's happened in other countries that it does come back, and we're going to be dealing with COVID for a while. And, no one seems to know when that's going to end. So everybody has to be mindful of the fact that you still need to do some of these preventive measures. And I don't know when to expect what. I just think everything always has a top and then you come back down. So where that is, I don't know. But certainly from where we started to where we are now, the practices that have been put in place across the state from a healthcare worker's perspective. I'll turf it off to Dr. Ashburn.
I will say one thing. I definitely believe it has made a difference. We were in the height of viral season, when this really hit and we started doing the social distancing and just anecdotally, personally, myself, I've noticed a significant decline in things, just the simple stuff, well, it's never simple, but, when you think about it, but your other seasonal viruses that we tend to see, significant decline, anecdotally in those. So I do think it has made a difference, this social distancing, and probably will be an uptick, in cases of COVID. I think once we open things back up again, I hope that businesses and, as we do start doing this, can come up with ways to continue the social distancing, but yet try to resume their, businesses and with some modifications, doing things a little bit more like this type of interview, and, and then when folks, that have to be in a workplace to do their jobs, obviously wearing masks and trying not to sit next to each other at lunch and those sorts of things that can, certainly increase the risk of spread. If we ever do, if we're ever able to ramp up widespread testing, which I think is going to be, that's a big thing. I think politically right now, ramping up widespread testing in the country, that would help as well, for us to monitor folks and know that, know that you're positive and, isolate yourself so that you don't infect other people. I think those are important things. So, hopefully not a surge, an overwhelming surge. And, that's my hope, that we don't ever see that, but I think we certainly have to be prepared that we may see more cases as people start moving out and getting back out and going back to work.
And are you comfortable at this point in time with restrictions starting to be eased in our area, assuming that they are on May 8th?
Again, like I said, I think we have to be prepared. I believe that, we have to get back to business at some point, and I think that, it's very important for everything, for the economy, for the government, to do that. I think we have to, however, kind of do it smartly, in my opinion. I think as long as people don't just say, oh, well, the restrictions are waived, we can go back to life as normal, and we shouldn't, we can't, we still have to be very careful and like I said, try to do our best to reduce transmission, reduce spread of this virus as much as we can. Masks and distancing and hand washing, all of these things are very important measures that still have to be used, even after companies go back to work. no financial expert by any stretch of the imagination as far as how long can we stay shut down, before we are in even a worse crisis as far as that goes. I think from a medical standpoint, if we, it would be good to continue doing what we're doing now indefinitely, but we can't. I do realize that, I think that, so we do have to be prepared to watch for this, and if we can do our best to keep this virus slow and try to keep the spread as controlled as we can until we can develop things like vaccines and such to hopefully control this down the road in the future. I think it's going to be sort of the way life is for the next year or so, as we really try to keep this in under wraps. But I don't think you can socially distance and socially isolate and keep businesses shut down for a year. That's not going to happen, and I do realize that.
And Kendra, speaking of business, obviously we're on the topic of reopening. Can you give us any insight on recalling furloughed employees, like maybe how many initially you might plan for?
So really what we're doing right now is, we just got notified on Monday. So we've been thinking about this for a while, but we're going to start next week and open up the endoscopy center, which is a freestanding center, so that people can resume those procedures, their colonoscopies, and get that operation ramped up. We're still going to keep our offices, the majority of our offices consolidated like they are now. And then we're bringing a couple more up in specialty practices, and we're going to manage it like that, so that as you bring those offices up, you slowly release those individuals that have been furloughed. Then we'll open up the ambulatory surgical center. So EVAN is fortunate because we have two freestanding centers, a surgical center and endoscopy center. So all of the patients who are backlogged, who meet the criteria to be done on a same day, but in an outpatient setting, we'll do there. And that goes to what Dr. Ashburn was saying. We're trying to keep as many people out of the hospital who can stay out of the hospital. Then we'll start the following week to do more of the cases that need to stay in the hospital, like hip and knee replacements. But they'll be done on a very, very small scale. We won't go back to normal capacity. So how we ramp up will bring people back according to the ramping up of the services. And so when you look at the way all of healthcare is consumed, if you're not doing as many procedures, you don't need all of the people that support like the coding and the billing and the collection of the accounts and all those things. So you bring it up in a step process. You're not opening one-day surgery in your hospital at the same time that you had been having them. So you need a fewer amount of staff. So this will be a really dynamic process. We're just starting to execute the plan this week, so I don't have those exact numbers. 60% of the workforce have been impacted in some way, either through furloughs or through reduced hours. Mm-hmm. So it had a huge impact, and slowly that's going to come back. But from an economic standpoint, you can't just flip the switch on and have everybody come back and then not have the revenue coming in to support the overheads of that workforce. So it's a challenge, and there's a lot we don't know, Eric. We don't know how many people will have been unemployed. How many people will be without insurance. We treat everybody. It's our charitable mission to take care of people regardless of their ability to pay, but that has an economic impact. If that number grows and the hospital's providing charitable care, that takes a hit on us. So it's got to be a slow, measured approach if I want to stay a strong, independent hospital for this region. And again, when I say I'm saying if Evangelical wants to stay an independent community hospital, we have to be smart about how we come back up so that we get on solid economic footing and don't derail. And I think earlier, as Dr. Ashburn said about like this type of call, I think that there's a lot that we've learned through this crisis that we've even yet to identify in how we become more efficient and better at what we do. So we're still, as a team, talking about what we can do differently as I mean, you take 400 people and send them home. All of a sudden, you look at work differently. It's kind of the conversations around telemedicine. All of a sudden, we were sort of slowly easing into that. And I think the national statistic is 22% of hospitals were using telemedicine. Now it's up in the 60% of people. The consumer is going to say, well, if I could do that in a crisis, why can't I see my doctor that way on a regular basis? I mean, these are the disruptors that you're going to start to see in healthcare. And we want to study all of that and think about that as we come back up. So long answer to a short question, but I don't have the numbers, but it will be a purposeful, measured coming back up.
Is the hospital still financially healthy?
So we had good financial reserves. I've been pretty clear about that in the past. We were an A- rated hospital. We had met very good financial metrics. We had good days of cash on hand. We saw our investments like every other individual tank. And so we had seen what, I always deem as our savings account begin to be draining. The markets have come back up, which is a positive. We saw we had a good month of March prior to closing. So we were pretty much at break even in March from an operational perspective, but April was the biggest hit month and it's not over yet. So we have not seen the impact of what April meant to the organization. So it's encouraging to say here by mid-May, we're going to be coming back up. At least we're going to have more of a revenue stream. And I think the public is beginning to realize that they can safely use our services. And, as the restrictions are loosened on the public, I think we'll also see some more of that business come back.
You just said yourself, the public is starting to realize that they can safely resume your services. Have you found that to be true, that patients, that some population of your patient set was afraid to go to the doctor's office or afraid to go to the hospital?
Sure. I think early on, I think it's human nature. I mean, it was so quick and so fast and everything's shut down, and then you're stuck at home and you're just watching TV and your anxiety level is skyrocketing and you're hearing this information and that information, and the last place you think you should go is to a hospital where you're going to run into COVID patients. And I just have told people there's never been a safer time to come into the emergency room than right now, because there's no one waiting and you get taken to an area where you're not going to cross paths with somebody that has been deemed to have or potentially have COVID. So I think that people held off in seeking some of that care. And we're seeing in the offices as we slowly open them back up that people are feeling comfortable in those areas. And all of the protections are in place. You won't be sitting in big waiting rooms with 50, 60 people. Your appointments will be different. You'll be coming in and hardly waiting and being taken back to a room, and you'll be moved through in a different way. And I think all those things will assure the public. But I think of it, we had seen people who waited too long sometimes to get care, and they ended up in a more difficult situation had they just come in right away when they were having some symptoms. But I think it's human nature. In a crisis like that, I mean, all you were seeing was people were really frightened, and what you were seeing was like what was taking place in Seattle or in New York City, and it was frightening. But it is very safe and appropriate to get the care that you need. And so, but you don't know how long it's going to take economically for people to get back to that total comfort level with seeking healthcare services. So between the number of unemployed and those without health insurance, coupled with, when we flip the switch back on, it's not going to be the volumes the way they were the day that we closed. So we have to bring the workforce back in the same manner.
Dr. Ashburn, one more for you, and I know you both have been very generous with your time, so thank you so much. Dr. Ashburn, what do you think the biggest misconception has been among the general public when it comes to the disease itself and its treatment?
I think that there's a tremendous amount of anxiety and fear about the disease, which is justified, because if you do get really sick from it, you can get very sick, and we know that. I think, I've seen two very common misconceptions. One is, I'm going to get sick and I'm going to die, it's still even though there are people that are dying from this disease, it's still a very low percentage of people who are infected that die. And then the other is I'm young and I don't have any medical problems. So if I get sick, I'm going to be fine. And that's not always the case either. You know, we don't know. There's a lot about this disease that we're still trying to figure out and we're still trying to understand. And we don't know who's going to get sick. You know, we know that folks that are older with medical problems are more likely to get seriously ill and more likely to die. But that doesn't exclude younger people with no medical problems from getting seriously ill. So, you know, that's the important, you know, where I've seen some misconceptions about the disease itself is that, you know, you still need to take the precautions, you know, you need to take those precautions for yourself and for the people around you, you know, that's the most important part of it. You know, don't feel that you're invulnerable because you're young and healthy. I think you have to be still taking those precautions. And then the other, you know, part of that is you can still get infected, not get that sick, but you might spread that disease to somebody who could get very sick and be very seriously ill. I think that those are the important things. And I'm hoping, and I think we've seen a shift in that, and people are starting to realize that that's the way it goes out in the community. I think that early on, you know, there was, you know, when we were first hearing about this disease in China and folks were saying, oh, it's just older people that are dying. And I think that now people are realizing it's not just the older people and are taking it a little bit more seriously from that standpoint. You know,
Kendra,
those are important aspects.
Oh, my apologies. I didn't mean to step on you.
It's okay.
Kendra, I'd like to offer you, you know, the last word.
Last word. I think that I'll do what I sort of started out with at the beginning, is that this is the community's hospital. And, you know, we've worked very hard to do right by the community in how we manage and prepare for this crisis. And as we come back up, the same deliberate approach to how we managed and kind of got ready for COVID will be used to safely bring the hospital back up. This is about making sure that we're focused on safety and, you know, following the science of the way this disease behaves. So I think, you know, and we're transparent. We'll share with the community, you know, what we did to get this hospital ready, and we'll share with the community what we do to come back up with our services.
Dr. Ashburn, Kendra, thank you both so much for your time.
Thanks for watching One on One. Be sure to tune in again for another edition.